Okay, Chapter 8, Introducing the Atrial Rhythms. Now, at the beginning of each and every one of these chapters, you're going to notice it goes over the same thing. So we're going to kind of just skip through that. As long as you've learned how the normal impulse goes through and the rates and all of that, then that should probably just bore you. So I have enough problems with boring you guys, so we'll try to keep that to a minimum. So origin of the atrial rhythm, we know that they're all classified the side of their origin, SA node. So we're going to talk about atrial dysrhythmias. So for the most part, these are not considered life-threatening, but they certainly can become an issue that needs to be tended to. So here we go, SA node, internodal pathways, all that stuff that we've talked about, how the impulse travels all the way down into the ventricles. You guys know this part, and if you don't, you're going to want to, because you're going to see it over and over and over. Different pacemaker sites: SA node 60 to 100, your AV node, atrioventricular is 40 to 60, and then your Purkinje network, or even just your ventricular rate, is going to be 20 to 40. So our first rhythm, wandering atrial pacemaker. So a lot of times, just by looking at the titles of our rhythm, we can figure out quite a bit. So right away it tells us that it's atrial as well as wandering, and that's kind of an interesting word to think about with a rhythm, but you're about to find out why it's called this. So this occurs when the pacemaker sites wander or travel from the SA node to other pacemaker sites within the atria. So, but the thing is, when you look at your rates and all of that, and even your definition of what a sinus rhythm is, the SA node still remains the basic pacemaker. The difference is you're going to see or observe at least 3 different P waves. So what we mean by that is you're going to see guys like this. So you see a difference here as opposed to here, as opposed to here. These things are either moving, their PR interval is changing. You can see that here. This guy's PR interval has changed from here to here. You can see the morphology or the shape of it has changed as well. Everything has changed about it. So the size and shape can vary according to the site of the origin. As well as you may see this, the P waves may appear upright, they may be inverted, which means they're upside down, or they may even be absent. So the absence of a P wave may indicate P wave is buried in the QRS. So you would probably see that QRS is going to be a little bit wider than normal. But your PR interval can vary as well based upon the point of the origin. Point of origin meaning where that pacemaker site is starting, because it may, depending upon how far or how short it has to travel, that's how you see your P wave. And typically it produces no symptoms. It's only recognized by EKG observation. So really the main difference we're going to see here when we go over this, the rate still 60 to 100. The rhythm, it could be slightly irregular, but the changes in the shape, size, and location from beat to beat, that's going to be the big thing for this wandering atrial pacemaker. And once again, we see our PR interval has changed. It's changed again here. Our shape and size and everything about our P waves have changed within this. Remember, it requires 3 or more P waves to that's changing in its shape, size, morphology, all of that, for it to be a wandering atrial pacemaker. We move on to our multifocal atrial tachycardia. So multifocal, remember your foci is the spot where the heart is being paced from, and this is saying it's multifocal, so it's got different spots that it's being paced from. So it's a variant of wandering atrial pacemaker, and that's what we saw within that wandering, when we saw wandering atrial pacemaker. Remember, it was moving around, its pacemaker site was actually moving around, and that's why you would get the changes within the P wave. The difference here is that second point is that it occurs when the rate reaches 100 beats per minute or greater. Now sometimes this can be confused with atrial fib, and we're going to go into what makes atrial fib in a second, and it'll make a lot more sense of how to distinguish these two. Sometimes you can see this in people with COPD or dig toxicity, or even just some basic electrolyte imbalances. So you can see that it does appear that it's irregular at times. Obviously this P wave looks completely different at each and every time. And our rate, for the most part, depends on really where you look at it. So if we were to just jump off right here, 151, so about 110, and they're all kind of averaged about that, and you have even some faster here. So multifocal atrial tachycardia. We move into our PACs, premature atrial contractions or complexes, depending upon how you want to say it. When I was in school, and since then I was taught to say contraction. So that's probably what you'll hear me say, although the point of this, as we'll get into, is the contraction is actually a mechanical word, and the complex is more of the electrical word, and that's what we're looking here for, is the electrical representation of what's going on. So a PAC is a single electrical impulse that originates outside the SA node in the atria. So you see here that it can occur in the atria, or the AV junction, or even in the ventricles, and this is a premature contraction. So that is arises earlier than the next expected beat. And this goes on to tell you that what I just said. We're talking about mechanical versus electrical. So looking at the differences, our rules, these are things you've got to remember that you need to memorize. Rate is usually going to be normal. Rhythm is going to be regular, except for this premature beat. And then the P wave, it differs in shape, size, and location from normal P waves. So think back to that wandering atrial pacemaker. It's kind of like that, where you had the differences of the P waves relating to the QRS for each and every one, or for 3 or more. This is going to be for one that's a beat that's premature. So what we're talking about is this. So you see we've got P waves here, and then we have this early beat. It's kind of out of nowhere, right? This looks pretty regular. If you were to march it out, it looks like it would match up pretty regular. And this guy looks pretty early, and you can tell that the P wave is now earlier. Your PR interval has changed from what these PR intervals were to here. So premature atrial complex. Now, this is something to pay attention to, because you'll see this over and over within EKG. So two sequential PACs, so meaning you have a pair of them, then you would call that two sequential PACs, or you may even see the word couplet. From me, you're probably going to hear the word couplet rather than sequential, but just recognize both. Atrial bigeminy, so bigeminy meaning every other beat is a PAC. Atrial trigeminy, every third beat is a PAC. So trigeminy, bigeminy, that should make sense. Bi is paired, so every other, tri, every third. And they look very much like the normal complexes of the underlying rhythm. It's just, remember, it's that P wave that has the difference, as well as it's early. So a lot of different things cause it. The most things that I've seen cause it probably is just stimulants, so a lot of caffeine, a lot of coffee, or even some stimulant drugs can you'll see that. But when you have any premature beat that occurs more than 6 times in a minute, it is termed frequent. Now, reentry dysrhythmias. So these are kind of weird. Reactivation of myocardial tissue for a second or subsequent time by the same impulse. So what we're talking about is, hang on, let me get to my page here. Here we go. So what we're talking about is, this next page has a good thing. So this rhythm is going here, or not rhythm, but a pulse is moving this way, impulse, and it activates the muscle fiber, and instead of going out into the muscle fibers and going away after the contraction, it makes a sharp little turn and goes right back. Well, then it just becomes this type of deal. So it comes through here and goes through and is reused over and over and over, or at least twice, really. So essentially it is a short circuit. Your text will tell you that it's kind of a short circuit of the electrical conduction system, and what happens is somehow this impulse is either delayed or blocked, And that's how it just continues to be used. Most of the time, that impulse is used one time and it causes the heart to contract and it goes away, but not all the time. So impulse moves in cycle throughout the heart tissue, and so you get a series of fast depolarization after that. And that's what we're talking about here. That's how we get this really fast heart rate here. Now this does seem a bit, well, you can see here, so conduction delays, blocks include hyperkalemia, ischemia, a lot of different things. Now it seems weird to me that they put this here because it seems like this fits a lot more along the lines with SVT, but this is the way they put these pages together, so I didn't want to change the slides up and throw people off. So atrial flutter is what next thing that we'll talk about. These are two words here, picket fence as well as sawtooth pattern. Those are two things to remember when you're looking for atrial flutter because they do kind of represent that. So you can see here we're talking about kind of a picket fence or a sawtooth, and it's very distinguishable when you compare it to your other rhythms. So it's a single irritable site in the atria. It initiates many electrical impulses at a rapid rate. So those are different atrial beats that are happening. So whereas before when we saw that reentry rhythm, and that's why all of this is bunched up together. But whenever you saw that before with the, we saw 1-to-1, an atrial beat and a ventricular beat. Here we're seeing 2-to-1, 3-to-1, 4-to-1. So these guys here are all atrial contractions, and then you have your ventricular contraction. So you'll see that we call these kind of 2-to-1, 3-to-1, 4-to-1, or whatever, but rather than the presence of the normally appearing P waves, you get a flutter wave. I wouldn't call it probably an F wave, because sometimes people call a fibrillatory wave when we talk about atrial fib. You might hear that as an F wave. So just better, in my opinion, to call it a flutter wave. AV node becomes the gatekeeper to the ventricles. So it allows things in and out, and then what happens is, based on the number of impulses the AV node accepts, the ventricular response is established. So it may accept 2, 3, 4 different impulses before it opens up to the ventricles. So here's what I was talking about, that conduction ratio. So you get 2 atrial contractions for each ventricular, 4 atrial contractions. So you see this conduction ratio of 2-to-1 or 4-to-1. So an atrial rate of 300, meaning you had 300 of those sawtooth waves or those flutter waves, will parallel a ventricular rate of 75. That's at this 4-to-1 rate. That's pretty simple math there. So 75 times 4 should be 300. Atrial flutter with a slow ventricular response. So you'll also hear that with an atrial fib. If the ventricular rate is less than 60, then it would be atrial flutter. You might hear SVR, so slow ventricular response. Or you might hear RVR for rapid ventricular response, and that's if the ventricular rate is greater than 100 and less than 150. So back to what our rules are. Atrial 250 to 300, that's not a rule necessarily, it's going to be there, but that's just an idea of the beats. The most important thing is that you have these sawtooth waves or your flutter waves. So here we see, here's what we're talking about, is these flutter waves here all throughout. You can see them, or sawtooth waves. And then atrial fib. So this is probably the most common rhythm that you may see, especially with your older geriatric population. You'll see this with a lot of people. Presents with 3 definite characteristics. This is important to know. It's going to help you to be able to routinely diagnose these rhythms properly, as well as it could potentially be one or more test questions for you. So the 3 rules of atrial fib right here. Notable absence of P waves, so you do not have a P wave. The P waves are replaced by F waves. See what I was saying? Now we're talking about atrial fib, so we still have this F wave. Excuse me. And then ventricular response rate totally irregular, or termed irregularly irregular. So our 3 rules: no P waves, you have fibrillatory waves, and it's irregularly irregular. If you remember those three things, atrial fib will never get you. So the QRSs are normally within normal limits. Multiple ectopic foci from within the atria is blitzing the AV node. So the atria is fibrillating, much like when we think about ventricular fibrillation, and it's just kind of quivering, and it's sending out all of these little impulses, all these little blasts, trying to work properly, but it won't. So the AV node is unable to handle or conduct each impulse, and then it allows them to just enter randomly. So the big points here: irregularly irregular, no P waves, fibrillatory waves. Those are our big pieces for atrial fibrillation. Those are what you might hear take-home points. That's what we might call those. So, atrial fibrillation. So you can see right away when you just step back and look at this. This looks like garbage. It's just all over the place. So it's irregularly irregular. Let's just look at our atrial fib. Okay, rules. So P waves. Let's just see if we think that might be a P wave. Well, it's all over the place. We have no P waves. And then you have just these little bitty waves that are just all over the place. So fibrillatory waves, much like ventricular fibrillation, right? That's kind of just all over the place like that. And it is irregularly irregular. So probably the easier way to get you a good rhythm on this, a rate on this, is just to go ahead and do your 6-second method. 1, 2, 3, 4, 5, 6, 7, 8, 9, somewhere in the 90s. That's probably going to be your easiest way to do that if you need to have a rate. So this is says it can be chronic in nature. It typically is. Many of our older patients are going to be like this, and they're on medicines to either help it or hopefully get rid of it. You see that the treatment, we want to slow part of the problem is when they get to with an atrial fib. Remember we talked about the SVR, slow ventricular response, less than 60, or an RVR, greater than 100. Part of the problem is within atrial fib, you lose what's called your ventricular, or a good portion of your ventricular kick, and that has to do kind of with cardiac output and how the ventricles expel all of the blood out. So you have a couple of problems there. Number one, you're not getting a good ejection fracture because the ventricles aren't emptying. Number two, if you think about it, and I wish I had a slide up here to show you. I know there's not one now. If you think about it, I'm just going to draw on here. Now I actually have a marker. Oh wait, I do have a marker. Hang on. Okay, let's use red. It's pretty. So here's your heart, right? And we have our there you go. So our ventricle. So what happens is you get this blood in here and you have this fibrillation, all this stuff going around, and now this blood is just kind of doing this whirlpool effect in the ventricle itself. So it's doing this in here. It's not all getting expelled out that way. So what happens is while it's in here kind of recirculating, as blood does, it will clot up. So little clots start happening, and now all of a sudden, boop, it pops out and it goes into the circulatory system or into the pulmonary system. Excuse me. And now you have a microemboli floating around, and that's why these people end up having strokes. So that's why you'll see a lot of people on atrial fib that have, that are in atrial fib on Coumadin to help keep that stuff free of emboli, free of clots. So hopefully they won't have strokes and MIs and all the stuff that goes along with that. As well as like when they schedule people to go in and get cardioverted for this, they'll make sure that they put them on like a 2-week pretty heavy dose of, I don't know if it's Coumadin or what they're using now, but pretty heavy dose of anticoagulants so they can get all of those things broke up, because they're about to shock the heart and expel everything out of it, and they know that there's a potential for issues. So they'll make sure that is handled properly. So SVT is our next rhythm. So encompasses all fast or tachy dysrhythmias in which the heart rate is greater than 100. Okay, hang on. Yeah, I'm not sure why this says this right here, because it shouldn't. That is, so let's talk about this real quick. This is like my third time on this. I wonder if I notice this every time and just forget to fix it. So supraventricular tachycardia, okay? We understand tachycardia because it's 100 or greater. Supraventricular, meaning above the ventricles, right? So it's being paced in the atria. So this is talking about I guess we're just going to make some generalizations here that applies to any tachycardic rhythm originating above the ventricles. But when we talk about supraventricular tachycardia, we're gonna talk about a very specific rate. That is how we'll classify that. So, like I said, I'm not sure about why that's even in there, but it is. So let's move on. Now, this is an important word to recognize here: paroxysmal. So it refers to the sudden onset and or cessation. So you were watching them, and they were just a normal sinus rhythm or even sinus tach, and they went into SVT, or it stopped in front of you. Or sometimes it can be referred to as, they were just sitting there, and then this just became as a sudden onset of this, and they weren't necessarily hooked up to the monitor, but that's what paroxysmal is. So it was just referred to as sudden onset. So these occur when rapid atrial ectopic focus overrides the SA node. So it can resemble a rapid sinus tach. So SVT, here's the main point, is atrial and ventricular are greater than 150. Depends upon where the curriculum that you look at. You may see 150 or 160. So we're going to go by 150, but in the event you're looking at another curriculum or something else out there, you might see the number 160. So don't get freaked out. Now you'll see, is there a P wave before each QRS? Usually not discernible. It's because the rate is going so fast that you can see here. This is so fast, so everything gets squished in between here, right? There's not much space in between here, so everything gets kind of squished in. So there is going to be a P wave. It's just so cramped in there that it makes it really hard to see. So sometimes it can actually even kind of be hidden, not necessarily in the QRS, but it's just hidden here. So with this rate, we can see this is probably somebody who's going to be sick, because it's a rate of about 280. So you go from here, 300, and there's your next one. So this guy's, tacking along at 280 beats a minute, going to probably be pretty sick. We'd expect his cardiac output to be pretty diminished. We go down here, 300, right about 160. So remember, we start at 300, 150, and then this one's dropped back one box. So we're probably looking at 160, 170. I don't know. You can do the math to know what one of those 5 boxes would be. But we know that it's going to be SVT. Hope that makes sense. So a lot of things can cause this. You don't see it up here, but sometimes people that have been working out in heat that are a little bit dehydrated can have that. And typically the most that I've seen is probably excessive use of stimulants. Treatment. So we're going to do, first thing we're going to do for someone who is not sick, because this is a sick versus not sick person. Not sick is someone who is just tachycardic without all those symptoms, right? Remember that? We talked about whether they're symptomatic or not. So chest pain, shortness of breath, altered LOC, dizziness, lethargy, all those. So first thing we're going to do is vagal maneuvers. So we're going to have them bear down, essentially, to what it does is exerts pressure on the vagus nerve, and that slows everything down. So you can see down here, bearing down, coughing, squatting. What I found really good is you can do it either through a syringe or even a IV catheter. Make sure you take the needle out. But you can have them blow through an IV catheter or pull the plunger out of a syringe, have someone blow really hard through that. I used to always tell people to bear down like they were going to the bathroom, and then I had someone take me up on that, and they pooped their pants. So I decided to quit telling people that, and it's worked out really well for me. So, like I said, I think one of the easiest ways is just to go ahead and get a syringe and pull the plunger out, have them blow through that for 5 to 10 seconds. If you want to check it out yourself, it's really easy to do. You just go ahead and get your radial pulse, bear down for 5 or 10 seconds, being careful not to poop your pants, and watch. You'll feel how your pulse rate will slow down. Now, if they are sick, or if that doesn't work, then we're going to move on here to Adenocard. And that should be medication that you have already gone over and learned, hopefully, air quotes, hopefully. If not, you need to refresh. Make sure you're going to learn it, because you may see something about that very soon. This is going to be for someone who's not sick, because if they're sick, if they're having chest pain, bad blood pressure, all of that, then we're going to synchronize cardioversion. And we're going to go over these things when we get into ACLS about how we synchronize cardioversion and what the dosage is and all of that. WPW we won't go too much into, but it's characterized by 2 AV conduction pathways, and then you have a delta wave. You can see that right here. So this slurring between your P wave, this slurring here, is going to be your delta wave. And the problem is it's due to the ventricles stimulated by the impulse originated outside the normal conduction pathway, so you don't have those nice, sharp, crisp little lines. So the classical or clinical significance of the atrial rhythms. Now, wandering atrial pacemaker, not much. It can be a precursor to a lot of things, but there's nothing going along with it. PACs, isolated ones are not. I've never seen anybody that had PACs that was sick, so I'll just put it that way. Frequent may signify underlying heart disease, so they might have some chronic issues going on. Now, atrial flutter, typically, you see the ventricular rate is normal. That's well tolerated. If the ventricular rate is fast, you'll get a decrease in cardiac output, and a lot of it has to do with what we're talking about. It has that decreased filling time, decreased ejection fracture, all of that. Treatment directed to decrease the ventricular rate, either with medication or cardioversion. Atrial fib. Rapid atrial fib treatment is to decrease the ventricular rate with medication or cardioversion. So remember the 2 things we talked about, slow ventricular response or rapid ventricular response. Typically you're going to see RVR. Typically you're going to see rapid ventricular response, and you see here this word atrial kick that we talked about. So they're at risk for that little emboli that we talked about. SVT can occur in patients with healthy hearts, may be tolerated for a short while. So some of the words you might hear: palpitations, heart skipping a beat, racing or running away, those kind of things. Those are people where it just feels, if you've ever had a little run of SVT, which I have once, it's kind of weird, as well as you feel everything beating really fast, and then it may just kind of go away, and you feel kind of oozy. So what I assumed then was my blood pressure was getting kind of crappy, but luckily I am a trained first responder like you guys, and I was able to take care of it because I did not want to call an ambulance in my town because I know most of them. If symptomatic, treatment directed at slowing the heart rate by use of vagal maneuvers, drug therapy, or synchronized cardioversion. So think about that: vagal maneuvers, drug therapy, Adenocard, or synchronized cardioversion. Okay, so when we talk about this, think about what each one of these things are. Vagal maneuvers, okay, drug therapy, we're talking about SVT, that's going to be Adenocard or adenosine, or synchronized cardioversion. What I suggest is you guys make, as we get into ACLS and all those things, you kind of make up your own little mnemonics, or I'm going to give you mine, but mine are kind of outdated because some of the meds don't go along with it anymore, so it may not make quite so much sense as it did 10 years ago when these meds were around. Strips. So anybody want to take a look at some strips? Oh, you do? Okay, well, let's take a look at some strips. Hang on, let me get my spectacles here so we're good to go. Talking about chapter 8. So let's look. Let's look for P waves. All right, they are all upright, but are they symmetrical and similar? I would say no. 1, 2, 3 that are all different. Looks like PR intervals could also be changed a little bit. So just by definition, right away, we're talking about wandering atrial pacemaker. Anybody disagree? All right, good. All right, moving on. Chapter 8, review strips. So looking for P waves. I don't see any distinguishable P waves, but what I do see is these flutter or these sawtooth waves. So I'm thinking right away this may be atrial flutter. What do you guys think? So I would say 1, 2, 3, 4. This is going to be atrial flutter with a 4-to-1 ratio. Now in the future, if you have a written test and or you're asked what is this rhythm and you say atrial flutter, I will not require you to say a 4-to-1 ratio. If you would like to, that's okay. You're more than welcome to. The one thing I'll ask you to do though is to make sure that you're right. So, I always say don't kind of get into something that you don't want to get into. So if you say that is a 4-to-1 ratio and it's really a 2-to-1, that's going to be wrong. So this is atrial flutter, or it's atrial flutter with a 4-to-1 ratio. Well, let's take a look here. So right away we see that it's irregular, and when you march this out, you can see these are irregularly irregular. So right away that should make us think about our rules, right? So let's go ahead and look for P waves. I see no P waves. I do see fibrillatory waves, and then as well as what was our third one? My gosh, I just had a brain fart. So absence of P waves, yeah, no, I remembered it. Presence of fibrillatory waves and irregular, and this is all over. Probably you might even, heck, I don't know, maybe you might call that a sinus arrest. I don't know what you might want to call that. So if we were just to start with our regular rules, we know our rate is going to be kind of all over 1, 2, 3, 4, 5, 6, somewhere in the 60s. And then our rhythm is irregularly irregular. P waves, absent. PR intervals. It's kind of hard to have a PR interval, isn't it, if we don't have a P wave. Moving on up. So let's see what we got here. We got P waves. That's P wave. This guy right here, he's early, isn't he? He looks a little different. So let's go ahead and we look for his P waves. We can see what normal P waves look like. That might be a little bitty P wave, or it could just be absolutely missing. So let's keep moving here. So we see this looks pretty normal. This looks pretty normal. Whoa, another early beat. Here's a P wave, but look at the PR interval. It's changed as well. So what I would call this, if I had to guess, meaning tell you what it is, I would call this sinus rhythm with a PAC, and it appears to be, that would be the third beat from, if we're just working left to right, we assume this is the number 1 beat. So trigeminal, right? 1, 2, 3. 1, 2, 3. I'd call that sinus rhythm with trigeminal PACs is what I would call that. Let's look at one more. What do you guys want? What do you guys say? One more to go. I put somebody to sleep, I know already, but wake up. Here we go. So looking for P waves. Don't really see a discernible P wave, do we? Right, my gosh. Let's see. 300. Right here is 150. So that's going to be about 30 per box. So we're looking at about, what would that be? 270? 265. So just by guessing, I'd guess he's pretty sick, this person right here, because having a rate of 260, 265 is not good. The heart has a hard time maintaining cardiac output. But we know that's greater than 150 or even 160, depending upon which you choose to go with. And that's about it. I had to talk about that, right? QRS looks pretty normal. No absence of P waves, no PR intervals. All right, well, that's that. That is that, right? So you got a few more to work out on your own. I don't want to steal your thunder because I know you're having fun with this stuff. So you guys work through that stuff. Let me see if there was any. Hang on, give me 1 second here. Let me see if there's any take-home points that we want to talk about. Wandering atrial pacemaker. Remember, you had 3 or more P wave changes, right? Because the foci is traveling, right? The pacemaker site's traveling. Multifocal atrial tachycardia. So it's kind of a variant or a change, a difference of wandering atrial pacemaker, meaning it's faster. Remember your atrial fib. was your 3 rules: no P waves, no discernible P waves. There is some fibrillatory waves present, and then irregularly irregular. When we got into atrial flutter, you had your sawtooth waves or your flutter waves, or was that picket fence or whatever? Let's see, anything else? And your SVT. So pay attention, read up on your SVT. Make sure that you're able to figure that out. Vagal maneuvers, adenocard, shocking them. All right, guys, that's it for atrial rhythms. Have a good one.